Good morning. This is Dr. Ara Duke-Majan, broadcasting live from the Surgery Center of Viera, Duke Spine Institute, February 18th, I believe. Today we're going to be doing two surgeries. The first is a Duke laser disc repair, which is an endoscopic spine surgery to repair herniated discs. And the second will be another Duke laser disc repair. Both of these cases today are in the lower back. These patients have herniated discs in their lower back that are causing back and leg symptoms. Our first patient has left leg symptoms. There are two herniated discs, L45 and L5S1, that are causing back and leg symptoms. One of those discs is particularly bad, L45. Now we're going to get started. If you have questions, feel free to type them in the dialog box. All right, you want to show me the MRI? Go ahead.
I'll get him, Luis.
All right, go ahead and scroll. Yeah, keep going. You're doing good. Keep going. Yep, keep going. All right, other way. Keep going. Keep going. Yeah. Who's asking?
The lights, please. He's asking for lights, so he can use that one. We're good.
You want light?
I'm good for this part. No, I'm good for
You can pull this towards you, perhaps, and use it up there.
I just don't want you to be able to see.
Yeah.
Is that good?
Is that? You can pull it harder. Yeah. You can pull that whole arm, and as long as it doesn't block the camera, we're good. Yeah, you're fine. So you can angle it. And
That one is good for you. Do you want to?
yeah, I'm fine. Okay. Sir, this is Dr. Duke-Majan. All right, so we're going to get started. You're going to be awake for the very beginning until everything is in place, and then we're going to put you to sleep, okay? If you feel pain, I want you to say, ouch. I'm going to want to know if that pain is in your back or if it's down your leg, or both. So when you say ouch, I'll give you some more medicine to ease the pain, but I also want to know from you it's in your back or down your leg. All right, we're going to get started, okay? All right, first thing I'm going to do is, this is my hand, I'm just feeling around, and then I'm going to give you an injection, bicarbonate. And that injection is with some numbing medicine, okay? So you'll feel me inject. How's our blood pressure? All right, good. So let's get it down. I want it in the 90s. All right. You'll feel a little stick and burn, okay? That's normal. Don't be alarmed. Does that burn much? All right. Yeah, this first part of the surgery is always the worst for patients. 5 cc's injected. Let me know when you're at the target range. So people ask me all the time, why do you do the Duke laser disc repair surgery? Why are you doing surgery on this patient? And it's a complicated answer, but we're doing surgery for not a diagnosis of a structural abnormality necessarily. We do surgery for symptoms that are related to a structural abnormality. So there's many people around the world, millions of people, billions of people perhaps, with herniated discs. And 90% of them don't have any symptoms from their herniated disc. So just having a herniated disc is not a reason to have treatment. Whether it's surgical or non-surgical, it doesn't matter. What you have to have that necessitates treatment is symptoms. So you have to have symptoms from a herniated disc. Okay? Another example would be excuse me. Well, another example would be allergies, right? So if you have allergies, but you have no symptoms from the allergies, you have no symptoms at all that bother you or interfere with your daily activities, you just have allergies, there's no reason to treat them. We treat herniated discs only when they cause symptoms. And the kind of symptoms that patients can have from a herniated disc that respond well to treatment, particularly the Duke laser disc repair, is back pain or neck pain, and symptoms down into the arms or legs as a result of the herniated disc. It's real important you lie still, okay? So leg symptoms, arm symptoms can be the same. They're pain shooting down the arm or leg, numbness in the arm or leg or hand, feet, pins and needle sensation, we call it tingling or paresthesias, and weakness in a muscle group. So if patients who experience weakness developing in their leg, numbness developing in their leg, tingling with pins and needles developing in their leg, or pain shooting down their leg, those are signs of a nerve root problem, an issue with the nerve root, whether it's compression or irritation. There's something going on, and if there's a herniated disc that's causing it, that would be something that would respond well to surgery. So herniated discs, for the most part, don't need any treatment at all, but when they do need treatment because they're causing neck or back pain, arm or leg symptoms, then the first treatment is going to be usually a shot, and that shot is called a steroid injection. Steroid injections usually only work for pain. They don't work well for any other symptoms, typically, but obviously there are exceptions. So really the best treatment in the world for herniated disc is surgery on the herniation. And spinal fusions, artificial discs, laminectomies are all Duke laser disc repair. They're all surgeries designed to treat symptoms from herniated discs or herniated discs with bone spurs. Okay? When you get a herniated disc, you can get spinal stenosis, which is narrowing. Let me know when you're under 100 or around 100, below 105. All right. So I'm gonna keep bringing it down, but I'll go ahead and get started. All right, sir. Let me know if you're having any discomfort, okay? And I'll give you some more numbing medicine. This is the part I need your help with, okay? All right, so let's try to get it down into the 90s. That's just me putting some numbing medicine in. Shot? All right, so Sean, when I say shot, it means x-ray. So I want you to go to the x-ray view at that point. Shot. Lateral. And you go to the x-ray view for just a second or two, and then you come back. Same thing when I'm under the endoscope, okay? When I'm under the endoscope, you spend virtually all the time under the endoscope except when I say shot, and then you take an x-ray, you go to the x-ray picture for a second, okay? Shot. Let me know if you feel any discomfort. Shot. All right, so we're heading for the L5S1 region. I think you need to wag it just a little bit to get the end plate of S1 lined up. And you can see he has a little bit of retrolisthesis. Just a little bit, like 2 degrees of wag. I don't think you did anything there. Let's try again, just 2 degrees or 3 degrees and see what we've got. All right. So you keep wagging and then moving the base. You can't do that. Move my side south a little bit. I think you've moved the base too far south. Yeah, you've moved the base too far south. Yeah, you're still too far south. All right. Go ahead and release the wag for me. Shot.
Make sure it's not exposed. The blue machine a little, please.
Shot.
It's good? Perfect.
All right, lock it down there. Shot. Are you comfortable? Yeah. Shot. Let me know if you have any pain or discomfort. Shot. AP.
This is the end of the L5, right? It's kind of
Yeah, the L5 is retrolisthesis, so it slid back on S1. That's not something that's unique to this procedure. It's probably just the way he's been for years. It's probably... So this is an example of a spondylolisthesis being present. Go back to a lateral view. All right, so you're switching when I say shot, you're switching, right, Sean?
Yes.
And then you go back to the actual endoscopic view or the eye in the sky, third person, correct? Yeah.
Yes.
Are you comfortable? All right, just lay still, okay? Shot. You feel any discomfort? Where do you feel anything? Where do you feel it? In your back or down your leg? All right. In your back? Shot. All right, back is fine. That's normal. It's expected. Shot. That's one of your bad discs, okay? We got the first one down. All right. Blood pressure is 100 now? That's pretty good. I wouldn't let it go up any more than that. All right.
Mike, Mike, please, I need you to hold that up, right?
Yeah, that's good. Thank you. That's good. Thank you. All right. Any questions from our audience? We're going to make an incision. You're doing great, by the way, sir. Everything's going well so far, okay? No problems. So we make a 7mm incision. The whole surgery is done through this tiny 7mm incision. This is the smallest incision in the world for spine surgery, obviously. unless you're doing just a needle procedure on a patient where you're not doing any real surgery. But if you want to do real surgery, this is the smallest incision possible. Pretty much the next size up after the Duke laser disc repair is going to be about 20 millimeters, 21 millimeters. Okay, give me an AP.
We do have a question.
Sure.
How long do patients have to avoid bending and lifting after laser spine surgery, such as a microdiscectomy or even a laminectomy?
Okay, so, yeah, go back to a lateral. The question is, how long do patients have to avoid bending and lifting after, and then there were 3 different surgeries mentioned. But what I heard was after laser spine surgery, such as a laminectomy or microdiscectomy. Just to clear the record, laminectomies have been done for about 150, 200 years now in surgery. And nobody uses a laser during a laminectomy. That's an open surgery, traditional back surgery. A lot of bone is removed out of the back of the spine. Those procedures don't use lasers. And microdiscectomies don't really use lasers either. Those are done with traditional surgical instruments and approaches. The Duke laser disc repair uses laser. So how long after surgery do you have to avoid bending and lifting? I think it's the same for all 3 surgeries, to be honest. With my patients, I restrict them from bending for 6 weeks, and I restrict them from lifting for about 3 months. And the spine is really completely healed. It takes about a year to fully heal from those surgeries. But most people can go back to work usually within a matter of a day or 2. They just have to go back with restrictions. Shot? Yeah, this is the really narrow part of the spine right here. I told you this patient has 2 bad discs. The first one is L4-5, the other is 5-1. This one I'm working on right now is the most narrow area of the spine. And I can feel the herniation right here in the foramen. It is big. So, shot? Yeah. Are you comfortable?
I'm good.
No pain down your leg?
No.
Good.
No,
Huh?
no, it's not really great.
A little bit there? Okay. Well, that's normal. All right, we're going to be able to put you to sleep very soon. Okay?
Doctor?
So we're doing our discogram now.
Okay.
How much back pain do you normally have? So you do have a lot of back pain normally?
No, pull. He wants to pull a little bit more.
Sir?
I do.
Yeah. Okay. Where do you feel that? Huh? In your right hip. Right hip. Interesting. And your back? Do you feel it deep inside your back? Oh yeah, that's where I'm in your back area. So is that the pain you get every day? All right. Well, that pain is going to be gone when you wake up. That's the good news. How bad was that on a scale of 1 to 10? What was the worst that it got? 6? All right. 6 concordant at 4-5. Are you okay? How bad was that on a scale of 1 to 10? Give me a number. A 10. Yeah. That was L5S1. That was the bottom disc, by the way. That was the one that was not as bad as the one at L45 on the MRI, but clearly causing you more pain. All right, well, when you wake up, we'll be done, and everything's going really well so far. So I want you to count from 1 to 100 out loud in Canadian.
That's
I want to see which language you pick.
French.
Huh? All right. You don't want to count in French? Okay. That's about what I can count. All right, go ahead and start counting out loud from 1 to 100. Nice and loud. You're doing great. Keep going. Don't stop. So we have tested both discs, the L45 and the L5S1. And if you look at this patient's MRI and you know what you're looking at, most doctors would only treat L45 based on the MRI, and they would be wrong, 100% wrong. And that's why back surgery gets a bad reputation. It's because, honest to God, there's probably only me in the entire world and maybe one or two other doctors that know what they're doing that would actually realize that L5S1 is causing this patient's pain. Even though on the MRI the disc herniation is maybe 50% as bad as the one at L45. Now, keep counting. So obviously the counting is to help you know when he's asleep. So obviously as little as you need, but this is going to be a little stimulating. Blood pressure is still good. Yep. Try to get it just a hitch lower if you can, if you're okay with it. I think most of the, if any bleeding at all, is already happened, but we are passing through the muscle, so this is where the opportunity to have some intramuscular bleeding is possible. All right, so I'm bringing my dilator down over the guide wire, and this is going to be the more stimulating part, and he seems to be okay. This disc right now that I'm working on is the one that caused him the most pain. He had 10 out of 10 concordant pain. I need that hammer again. 10 out of 10 concordant pain. So we know this is the disc causing most of his back pain, and the other disc is the one causing probably most of the leg pain. Now, some of you may be watching and saying, well, of course he has pain. You just injected some material into his disc. The truth is that if I injected somebody without back pain disc with that material, they would have zero pain. Unpainful discs, when injected, don't have pain. In other words, the act of injecting a disc with the dye that we just did does not create pain in a non-painful disc. So for a patient to have pain from the injection, they have to have what's called a sensitized disc, which is an injury to the disc that already exists, and inflammation usually within the annulus of that disc, which is what we're going to fix. Shot. Shot. That's perfect. Now the patient is having some discomfort, and that's why we have to put them asleep. The reason for their discomfort is obviously we're working on the pain generator for their back pain. We're working on the injured disc. So disc injury basically starts with a tear in the outer part of the disc called the annulus fibrosus. Yeah, blood pressure is good where it is. I would say you can bring it up a little if you want to. So we're through the muscle now. Sir, we're through the muscle, so we're not causing any more trauma. And the trauma to the muscle is really minimal because the tube is only 7 millimeters. And it's tapered when we go in, so it just spreads the muscle fibers. But sometimes you get a little vein in there, you know, or a tiny little muscular artery. That's what we're trying to avoid, having a hematoma in the muscle during that part of the procedure. That make sense? Yeah. Huh? Oh yeah, this is endoscopic surgery.
Oh, okay. I got
Yeah, we use irrigation. So.
you. I thought it was just leaving it in the hole.
No. It's supposed to. It's a release outlet. Now look, folks, you can see at 12 o'clock, there's this mass of tissue right there. That's the granulation tissue or inflammatory tissue within the annulus or annular tear that's causing this patient's pain. Okay? And that's what we're going to use the laser to ablate. Ablation of tissue by the laser is just delivering high energy to a tissue, and that tissue then vaporizes or breaks up into little pieces. It's basically what we do with the laser. At the same time, the laser can also stop bleeding. So there's a coagulation, which is always good in surgery. Surgeons are always, cutting things, but they don't want to cause bleeding. So the best way to cut tissue is to cut it and stop the bleeding at the same time as you're cutting it. So the laser provides those two things: precision and controlled bleeding with removal of pathological tissue. Pathological tissue here is the herniated disc and the annular tear. There's a piece of herniation I just got out. There's another. The blue stuff is the degenerated herniated disc. So why is it at the bottom of the tube? Because we shoved it from the foramen where it was pushing on the nerve into the disc. That's part of the technique. It's one of our little tricks. Is you actually take the herniation from a very dangerous area, which is in the foramen on the nerve root, and during the access of the disc, placement of the dilator, I actually push the herniation from where the disc is, from where the nerve root is, into the disc. So I can actually remove the herniation from inside the disc, which is actually the safest way to do it. And we do that in open surgery with a microdiscectomy. It's the same technique in terms of pushing the herniated fragment back into the disc and then removing it from within the disc. So if you have a herniation that's medial up against the nerve root and you can't reach it, you actually just push it, and you can get it to go down into the disc, and then you take it out and deliver it from the disc itself. So it's a much safer technique. This is all part of the annular tear. It's very calcified right here. There's a lot of, this is the osteophyte part. So when you get a herniated disc and it's been there a long time, it's no longer soft. After many years, it turns hard. And the reason it turns hard is it gets calcium deposited into the disc. Okay? And the reason there's calcium being deposited is that the body's way of dealing with abnormal tissue like disc herniation is to calcify it. It's one of the things the body does. And we talked about this in the past. It's called dystrophic calcification. How's he doing? Good. So, unfortunately for me, the more calcified and scarred up the disc herniation is, the longer it takes to do the surgery. Now, that's what we're dealing with right now, is a pretty old injury to this disc in terms of years and years that it's been here.
We have a question.
Yes, we'll take our question, our first question, or second question, I should say.
One of
Stand
our
by.
viewers is wondering, how do you treat people who have had fusion prior at L5S1 and are in more pain now than they were before surgery? Ever since that surgery, I also have issues in my cervical spine as well.
Yeah, so first of all, I'm sorry you're suffering. One of our viewers asked, what do you do about patients who have had a fusion at one of their discs, like L5S1, and now they're having more pain? Well, your pain is real, and it's coming from a structure. The most likely cause of your pain, if you had to ask me, is going to be the adjacent segment, basically L4-5. And it's easy to treat. The second most likely cause of your pain will be the sacroiliac joint. The sacroiliac joint, which is just below L5S1 fusion. So if your pain is lower than your fusion, then it's the SI joint most likely. If your pain is above your fusion, then it's the next disc, the L45. If your pain is at your fusion, then it's possible you've got loose screws and that the fusion never took. Or it's possible you have an infection there. So you would need an investigation with an MRI and some additional testing. But we could definitely figure out what's wrong with you at Duke Spine Institute, and we could probably fix it. About 95% of the time it's fixable. So your problem is fixable. You just need to go to the right place to get it fixed. Now, if you're thinking I'll just go to my local doctor and he'll fix it, there's about a 99% chance they won't be able to fix it because they won't know how to fix it, they won't know what's wrong. So you have to first go somewhere where they can make the right diagnosis, and that's what one of Duke Spine Institute's strong points is diagnosis. So if you don't have the right diagnosis, you won't get the right treatment. You understand what I'm saying? And when it comes to back pain, there's 32 different diagnoses, at least. And so if your doctor doesn't select the correct diagnosis, and it could be 3 different diagnoses, it could be 2 different diagnoses. If they don't identify the diagnoses, the causes of your back pain, they're not going to be able to fix them. It's really important to make the right diagnosis. I can't overestimate that. If you want to get rid of your back or neck pain, your doctor must diagnose the correct condition, because there's different treatments for different conditions. And treatment at one condition won't fix treatment in another condition. It's a very important concept. That's really the main reason, I think, why there are so many people living with chronic back and neck pain, is their doctors have not been able to correctly identify the source of the pain. Take this patient, for example, right? He clearly has a big herniation at L45. I can tell you right now, 98% of my colleagues would say, okay, let's go fix L45. And they would go fix L45 surgically. And the patient would wake up and they would still have the same back pain they had before surgery. Their leg symptoms may be better, but their back pain would still be there. And the reason is that the doctor did not correctly diagnose that L5S1 was a source of their pain, because on the MRI, you can't tell based on an MRI where someone's pain's coming from unless they have an infection or a fracture or a tumor. Okay? But 99% of back pain cannot be diagnosed on an MRI. You have to use a clinical diagnosis. You may have to do selective blocks of joints or muscles, but that's the only way to properly diagnose back pain. You need an interventionalist to do that. Basically, it's a special doctor, not myself, because I don't do this, but you need a doctor who can numb up different joints with Novocaine and subtract pain from that joint and see how the patient responds to that Novocaine in that specific joint or muscle. Okay? And by doing that, you can make the right diagnosis. So for the person who had L5S1 fusion, we can definitely help you. I just need more information. I'll need some pictures and I'll need some tests done, but don't lose hope or faith. Duke Spine Institute can figure out what's wrong and we can fix it for you. Now, I can't say that for other doctors in your area, and I can't even tell you 100% what's the exact cause of your pain right now talking to you over the internet, because I need to examine you. I need to see where your pain is emanating from. I need you to put basically a finger on the spot where your pain is the worst. And once I do that and get a few tests, I can tell you what's causing your pain, and then we can fix it. What's up?
Next one's not in PO.
So the next patient is here. When I went to get him in the lobby, he was drinking some water, and he had about 10 ounces this morning.
Wait.
He stated he didn't know not to drink water. He thought water was okay.
Well, hold on. Well, I told the patient myself that they can't drink water. So 10 ounces, is that too much water? Right, but we're not going to bring them back probably for another, till at least 10:15, 10:30, another hour.
Yep. I mean, if he's in PO for 3 hours, we'll give him some. You got a reg man?
It's your call. I don't want to, I mean, if,
So it's
we won't start their surgery at 12? Okay. When do they drink the water?
Since he woke up this morning, yep.
I mean, I gotta say that we have some responsibility there. Okay. I guess there's water in the lobby in the water fountain by the bathroom.
No, he had a bottle with him.
He had a bottle of water. Why didn't we stop him from drinking the water? Why didn't the front desk stop him?
It was like as he was walking.
I see. Okay. What is he? A 1 level?
One level, yes.
What is he? 4.5, 5.1?
It's a 4-5.
Out of town or local?
Also,
Yeah. So we'll just have to, until the anesthesiologist feels it's safe to proceed, we'll just have to delay the case. So don't give him any more water.
give him start an IV, give him 10 Reglan, give him, you don't have Pepsi, you give him Zantac 150.
All right. So folks, we're just discussing the next surgery. When you go to have surgery, it's real important that you don't drink anything, maybe a sip of water, like a sip with your medication, but not 10 ounces or 12 ounces of water. So lesson learned, hopefully. Not this patient we're currently operating on, but we're talking about the next patient. So that surgery will be delayed today until noon or close to noon, whenever the anesthesiologist feels it's safe. So why do people not allowed to drink before their surgery? Anybody know? Let's see if our audience knows. Let's see who's awake paying attention this morning. We'll give you guys 20 seconds to type your answer.
Aspiration.
Huh?
Aspiration.
Hey, I didn't ask you, Luis. I said type your answer. You can't say your answer. All right, so far we're doing L5S1 disc. Everything's going well. And again, to the person who asked the last question, yes, we can help you, but I need to see you. I need to do a video conference. Duke Spine Institute offers video conferences free. We do video conferences for people around the world. We don't charge for it currently. So you can have a 10-minute video conference with Dr. Duke Majan, the CEO and founder of Duke Spine Institute, and my team. We all sit down and have a nice little 10-minute video chat with you, and during that consultation I can look and see where your pain is, and it helps me determine the source. Without knowing the source of pain, there's no point in treating. Okay? Most doctors don't know the source of pain and they treat just blindly, and that's why patients don't get better with treatments usually. Okay? It's complicated, but back pain can be cured. The problem is at least 50% of patients I've seen with back pain, probably more like 60, 75%, have more than one source to their back pain. And fixing one source won't fix the other source. Look at that herniation right there. It's about to come out. But you can see how it's scarred down. It's stuck down. I'm having to free it up. There it is. Stand by laser. Okay, so what happens is the herniation actually gets scarred to the disc, to the annulus fibrosus, because of inflammation. Look at the gold color right there. That gold color is calcium. So we're taking the herniation out. That's an old herniation, been scarred up and calcified. It's probably several years old. And we go back in and it's gone. And I'm going to keep doing the annular debridement. Now, what I'm doing in the Duke laser disc repair, 95% of what I do is called an annular debridement. And basically, I'm cleaning up the annulus fibrosis. And this takes away the back pain and the leg symptoms, the leg pain. Okay? Why? And I'm the only surgeon in the world that does this currently. I'm sure there's people that are watching that are going to copy it, and that's fine. That's why I broadcast these surgeries, so that not just people, patients, or the public can watch and learn, but this is also to teach healthcare providers like doctors, nurses, surgeons, so they become aware of what's causing back and neck pain. It's the annular tear. I discovered that fact, that the annular tear is the source of inflammation that causes chronic pain. And I started treating it about 14 years ago with this laser surgery. We've published our results. in the National Library of Medicine and Surgical Neurology International. We have several articles that have been peer-reviewed and published. And in those articles, I describe the Duke laser disc repair procedure, how it's done. And there are 3 steps to it. The most important is the annular debridement that we're doing right now. Okay? But I'm the first surgeon in the world to discover and pioneer that technique and publish it. Of course, there will be others in the future, which is good, because this is the only way you're going to get rid of somebody's back or neck pain when it comes from a herniated disc. Okay? Most neck pain and back pain that's chronic does not come from a herniated disc. It comes from a facet joint. But facet joint inflammation rarely ever causes radicular symptoms. It can, but it doesn't cause it as commonly as disc inflammation. There's a reason for that. Facet joints are diarthrodial joints. They have a cartilaginous surface, and they get arthritis just like every other diarthrodial joint, like a knee, hip, etc., shoulder. But the arthritis that comes from a arthritic diarthrodial joint is nothing compared to the arthritis that comes from a disc herniation with inflammation within the annulus fibrosus. Okay? So the amount of inflammatory response to a herniated disc is like much greater than the inflammatory response in a diarthrodial joint like the facet joint. That's been my observation. Nobody will ever tell you that, but I will tell you that because I've treated thousands and thousands, and I've seen that to be true. So facet joint arthritis causes facet joint hypertrophy. It causes facet joint pain. It causes stiffness in the back or neck, depending on where you're having your problem. It causes pain, axial pain and paraxial pain, meaning to the side of your spine. But it doesn't cause arm or leg symptoms. That comes from the disc usually. Now sometimes the facet joints get so big they do cause arm or leg symptoms from compression of the nerve root, but that is extremely late stage, and those joints are massively hypertrophied, usually 4 or 5 times their normal size. Yeah, I'm fine from my standpoint. He's doing really good. So if you're happy with where he is, I'm happy with where he is. He's not really moving much. Now, I will tell you, we're getting to the outside of the disc, so it's going to get a little more uncomfortable. I think the floor is a little wet, guys. You need that towel down there, please. All right. So we're getting close to being done with this L5S1 disc. This, you can see the tear right there. The pink stuff is granulation tissue. This gold stuff here is calcium or bone spur. Just about done. Any other questions from our audience?
Yes, and we actually have a guess for why the patient could not drink water before the surgery. One of our viewers guessed aspiration issues.
Yeah, so the viewer is correct. It's aspiration. So patients cannot drink liquids or eat food before surgery because they're going to aspirate. Those stomach contents are going to come up and out, and while they're coming out, vomiting, they're going to be breathing, and they're going to breathe that vomit right into their lungs. And the reason they're going to breathe it in their lungs is because they're impaired, right? They're unconscious. So they'll be unconsciously vomiting and aspirating because of the anesthesia is making them unconscious. So they can't protect their airway. Like you and I, if we start vomiting, we don't breathe it in because we have this gag reflex that blocks our airway and prevents that vomit from going down into our lungs. But an impaired patient doesn't have those reflexes necessarily because they're under anesthesia. They're so sedated that the basic brainstem reflexes don't work. So anyway, they may be okay. They may protect their airway, but we can't take that chance because an aspiration pneumonia can kill you. So rather than risking having an aspiration pneumonia for an elective surgery, like fixing your back, we just put the surgery off. Fortunately, it's only water they drank, and they didn't have a steak and egg or anything like that. Otherwise, we'd have to cancel their surgery today completely. But we're just going to postpone it a few hours. And I'm sure our anesthesiologist will want to ask the patient if there's anything else they had since they admitted to having or were caught having water. It's better to put your surgery off rather than risk a life-threatening, injury to your lungs. It's totally unnecessary. You just have to wait a little longer. We do the surgery. So good guess on the aspiration pneumonia, or at least not necessarily a guess, but knowing the right answer. Thank you for contributing. Makes it more interesting when the audience answers some of the questions rather than just me. All right, so it's amazing how calcified this herniation is. It's pretty bad. But I think we're just about done. You can see the epidural fat. I'm going to zap a little more of this down here. This is the outer part of the annulus, doctor. No, that's just fat. The nerve root is going to be to the other side. I'll show it to you in a minute. A lot of times we get to see the nerve root. We're working right next to the nerve root. So you can actually see the nerve root many times. There's the nerve root right there. See the white thing? That's the nerve root. And we're just below it, right? That's where we have to work. We work right below the nerve root. Okay, don't move. Don't move. Everything's okay. You're doing great. So we're not going to damage the nerve root, but we're literally right below it. That's why the patient has to be awake for the surgery in the beginning, so that I know if I'm too close to the nerve root. They can tell me. They will tell me.
Another question.
Sure.
One of our viewers is wondering, how do you fix a break in the spinal cord? Is there any way to restore function to the lower extremities?
Just lay still. Everything's okay. You're doing great. Yeah, I wish there was. So one of our viewers is asking, how do you fix a break in the spinal cord? This is 2020. We still don't have a good fix for a spinal cord injury, a break in the spinal cord that renders people paralyzed. I think that we will soon. When I say we, I mean collectively we, not necessarily Duke Spine Institute, though we probably will be participating as well in restoring function. I personally believe where we are technologically is we're not at a place where we can actually reconnect the millions of neurons and axons that have been cut in a spinal cord injury. We're definitely very far away from that. However, where we are making tremendous progress in medicine is in bypassing the jam of information at the injury and going around it. And I think that that's going to be where you see the fastest, greatest progress in treating patients with spinal cord injuries. As a matter of fact, as a neurosurgery resident back in 1996, 97, it was an idea that I came up with to bypass the injury in a spinal cord shot. And at the time I was very interested in functional neurosurgery, which is restoring function to patients who lose function, whether it's brain function or spinal cord function. Sean? I was very interested in that field. And I thought of a way to bypass the spinal cord injury using a grid of electrodes on the cortex and then connecting that grid to the nerves going to muscles. And I never pursued it. I did functional neurosurgery, epilepsy surgery for my fellowship for 2 years around 2000, a few years later. And we certainly use grids and strips to monitor brain activity for epilepsy surgery. Shot? But I never pursued the idea of connecting it to the muscles because it was so like far-fetched, and there was just no mechanism for me to develop that as a resident. So I let it go, and then a few years later, probably about 5 years later, I read for the first time that I think French scientists thought of it as well, and they started experimenting, connecting the cortex directly to muscles. So same idea, or very similar idea as I had. Long story short, I ended up not pursuing that, but I think people are pursuing it, and I think honestly that's going to be the fastest way to get patients who have spinal cord injuries to have function come back, is to bypass the injury in the spinal cord and just create a new cable. Because I can tell you, it's virtually impossible to reconnect all those neurons and axons in the spinal cord. I don't want to say impossible, I say virtually impossible, because I don't want to eliminate people's hope. But the fact of the matter is, it's not even reconnecting millions of axons. The problem is the scar tissue that forms around those nerves that blocks the reconnection. And that's the secondary injury, secondary insult or tertiary insult to the injured spinal cord. So if we could stop all that inflammation and spinal cord damage through scarring, then that would be one big step in the right direction. But I can tell you right now, with all the microprocessors, microelectrode arrays, microsurgery techniques, we're going to be reconnecting people's brains with their muscles and bladders and anal sphincters long before we fix a spinal cord injury at the site of the injury. That's me right there. That's the latest shot. Okay. So for those of you watching who've never seen this before, the entire surgery is being done through a tiny little cut, 7 millimeters, on the patient's back, and the surgery we're doing is general category is endoscopic, true endoscopic. It's called full endoscopic spine surgery, as opposed to the fakers that don't do full endoscopic surgery. We do the entire surgery through a tiny little tube through an endoscope, whereas other surgeons who say they do endoscopic surgery and don't really do endoscopic surgery, they actually do it with a microscope or with loupes. They don't use an endoscope, a true endoscope. So we're coming through the neuroforamen on the left side. We're going underneath the exiting root. Since this is L4-5, we're passing underneath the L4 nerve root on the left side. And we're passing lateral to the L5 nerve root. Okay?
Jordan, you can go out.
So this patient has really bad narrowing right here from a massive disc herniation. And I even told the patient ahead of time, I said, listen, I'm going to do my best to get it all out, but you have some anatomical considerations here that are not amenable to being fixed with the laser. So I think we're going to get this foramen about 50% decompressed. That's my expectation, which should give this patient significant relief of their radicular symptoms. But this is a case where there's other things going on besides just the herniation. And those other things include arthritis of the facet joint. So it's a combination of the herniated disc and the large facet joint right behind the nerve root that's causing compression of the nerve root. So the nerve root's getting kind of sandwiched between an arthritic facet joint that's really, really badly arthritic and subluxing and the disc herniation. All right. The good news is most of this disc so far is soft. So soft disc herniations are usually respond very nicely to the energy from the laser in terms of vaporizing the tissue and getting rid of this stuff. But this is the part of the herniation right here. You're going to see how nicely it zaps away with the laser, quickly, easily, as opposed to the other disc where it was very calcified and scarred up from all that chronic inflammation that went on for years. So this is vaporizing away very quickly, you can see. Now when I get to the periphery of this disc, I may have more calcification, and that's going to slow us down a little bit. I wouldn't be surprised if that's the case. So I'm prepared for that. Anyway, we're on our second disc out of 2. So we've got about 10 more minutes, doctor. Probably about 10, 15 minutes maybe. And I'm hoping to be able to fish out a big fragment and make this patient very happy. Well, you can see there's been significant amount of damage to this disc though. Any other questions?
Yes, we do have a couple. One of our viewers is wondering, my neurologist sent me for an MRI with contrast of my cervical spine. They found an unknown fluid and sent me to a neurosurgeon, but the surgeon felt that it shouldn't be biopsied. Any guess as to what it might be?
All right, so one of our viewers is saying, Dr. Duke, they discovered some fluid in my, and I have to get clarification here, but I think I know what they're saying. I think they're saying within their spinal cord, not just within the spine, but within the spinal cord. And then my neurosurgeon said that just leave it alone, don't biopsy it. Any idea what it could be? Well, my best guess at this moment would be that you have something called a syringomyelia or a syrinx. And what a syrinx is a fluid collection within the spinal cord itself. In most cases, that syrinx is there from birth, and it's not causing any problems. It's just a variation of quote-unquote normal, but it's abnormal, obviously. Fact is, we don't treat it. We leave it alone unless it gets bigger. If it gets bigger and bigger and bigger, it's going to start causing numbness and tingling in your arms, weakness in your arms, pain in your shoulders, like as if you had a cape on, like a Superman cape. You would have numbness and tingling in that Superman cape distribution. So if you have a syrinx in your spinal cord, in your cervical spine, the doctor will probably leave it alone and not biopsy it, because biopsying it could make you paralyzed. That's the risk. That's why they don't biopsy it. And because we know the natural history of the syrinx, it doesn't do anything. It's not a problem for you. Now, sometimes syrinxes are also associated with tumors within the spinal cord, or congenital anomalies like Chiari malformation, where you'd be born with your brain basically hanging out of your hole in the bottom of your skull. So I'm sure the doctor looked for the tumor, and they looked for the Chiari malformation, or the tethered cord, which is a tethered spinal cord down in the lumbar thoracic region, where your spinal cord is stuck down to the bony elements in the back. All those things that are associated with syrinxes, and even trauma. Trauma can cause a syrinx to form within the spinal cord. So your surgeon probably ruled out tumors that are associated with syrinx and congenital anomalies that you're born with, like Chiari malformation, that are associated with syrinx. And once you've eliminated those bad things that need treatment, then you're left with a syrinx that's just there, not getting any bigger, hopefully, and you don't treat those. You don't biopsy them, you don't treat them, you leave them alone. So the neurologist did the right thing in sending you to the neurosurgeon, but you're probably going to need another MRI scan to be done in about 6 months, 3 to 6 months, to make sure the syrinx isn't getting any bigger. As long as it's not getting any bigger, then I agree the appropriate treatment would be to leave it alone. That's really the only fluid inside the spinal cord condition that I'm aware of that you would just leave alone. A syrinx. They call it syringomyelia. The other possibility is you have hydromyelia, but that's rare, and it's in the center of the spinal cord, and you don't do anything about that either. So syringomyelia and hydromyelia, 2 benign conditions left untreated and just monitored with MRIs, usually every 3 to 6 months, to make sure they're not getting bigger. And you do that for about 2 MRIs. As long as there's no enlargement, the surgeon will usually tell you, hey, we're not going to get any more MRIs at this point. You just need to let us know if you develop any balance problems, any tingling or numbness in your arms or legs, loss of control of your bowel and bladder function, like pooing on yourself, peeing on yourself. So the patient does that, lets the surgeon know if they develop any symptoms, and that's when they get another MRI in the future. So I would have to guess syringomyelia, my top number 1, 2, and 3 choice.
We have another question.
Sure.
Another viewer says, I had back surgery in 2017.
Uh-huh.
They supposedly shaved off the portion of my disc that was bulging.
Yeah.
But today I still feel 95% like I did before surgery. My left leg hurts all day, every day, and my left foot is numb.
Yeah. All right. So one of our viewers says, listen, I had a bulging disc, herniated disc. They did surgery, but I don't feel any better. I would get another MRI. You need another MRI, and then come see me at Duke Spine Institute. We'll fix it for you. We'll fix it for you for sure. Yeah. It just sounds like either you got a recurrent herniation or you had a residual herniation. It sounds like they just never really adequately treated the problem. It's very common, by the way. I see that all the time. Massive herniation fragment there. Good. Yeah. The nice thing about the endoscopic surgery you're watching right now is that I can see the nerve root. I can see the herniated fragments coming out. I can see inside the disc. When you do a microdiscectomy or a laminectomy, the surgeon can't see down there. Their vision isn't that good. I mean, this is deep, deep, deep inside, and really the only tools we have to see deep inside is a microscope or your own eyes with a loop magnifier, which is totally inadequate to do this kind of surgery. So the endoscope I'm using right now, that you guys are watching me use, this thing looks inside the disc. I've actually seen single red blood cells coming out of a little vein one time. And you can actually see all the problems directly with the endoscope. So this is truly the best way to do disc problem surgeries. Anytime you have a disc herniation, stenosis, pinched nerve, you can see it's everything so well, and the incision is so small that patients heal up very quickly as a result. So in my opinion, the microdiscectomy is really an outdated procedure. Unfortunately, it's all most surgeons know how to do, so that's all they offer their patients is microdiscectomy. But what you really need is you need endoscopic surgery like this. You can see the tear in the disc. There's the annulus fibrosus that's torn. There's the nucleus pulposus, the blue stuff that's stuck in the tear. So I'm debriding this tear. I'm debriding the annular tear so that it'll heal properly because it's not healed properly. I'm getting rid of the interposed nuclear material, the herniation. So you can't see all this, folks, when you do a microdiscectomy. Your surgeon doesn't see any of this. Zero, zippo, none of it. They're literally looking into a dark hole. And this is inside the disc. This is where most of the herniation is. The only herniation they can actually see without using the endoscope is the part that's actually outside the disc, and this is all within the disc. So 90% of what I do is within the disc here. That's because the worst part of the herniation is usually inside, still inside the disc, trapped. Stand by. And I use grabbers, pituitary grabbers. That's the name of these things. It's called the pituitary because it was originally used by neurosurgeons to take out tumors in the brain in an area called the pituitary gland, which is located right between your eyes, at the back of your nose. And they're long, skinny grabbers so they can take chunks of the tumor out. You know, now I'm using them to take chunks of a herniated disc out. So, similar application, but just not on the brain. And these are used traditionally in spine surgery by neurosurgeons. Woo, big annular tear. Look at that thing. This is perfect. Look at the pink color. That pinkness is inflammation. This is the source of the back pain. So I have to vaporize this stuff, get rid of it. He's moving around right now because I'm right on the tender spot, so to speak. But this is exactly why people have back pain or neck pain from a herniated disc, is that granulation tissue that's developing from chronic inflammation. You can see all the scar tissue. This is very chunky, scarred up stuff because of the chronic inflammation once again. So the source of back and neck pain in people that have chronic pain is inflammation, chronic inflammation. The word chronic just means it lasts longer than, say, 6 weeks. You know, it's arbitrary. Some people say 2 months for chronic, some people say 6 weeks. But chronic usually in medical terminology means longer than, you know, let's just say 2 months. So if you have anything longer than 2 months, you have a chronic condition, right? So I have sinus problems. I've had them for 20 years, so I have chronic sinus disease, right? If you have a fungus on your fingernail that's longer than, 2 months, then you can have chronic fingernail fungus. So the word chronic just refers to how long you've had it, right? So having children is a chronic condition too, as long as you have them longer than 2 months. Great questions we've been getting, by the way, from our audience. Thank you for asking. Questions are always appreciated at Duke Spine Institute. We like questions. The reason we like questions is it helps educate you, which is why we're really here. We're here to educate the world, the public. And when you're asking questions, it means we're helping you to understand issues better when it related to spine. And that's our mission. That's our goal here with the foundation. Our foundation is designed to help educate the public and to perform research. Research and education. Duke Spine Foundation. And if you're thinking about, hey, I need to donate my money to some foundation this year, think about the Duke Spine Foundation. We could always use donations. All right, for those of you who don't know, Duke Spine Institute has obviously a website, www.dukespine.com. We also have an app now for the iPhone or the iOS Apple platform, and we have an app for the Android platform. So though the app is free, we don't charge for it. We don't even advertise on it. Like if you get free apps, normally they advertise to you. We're not advertising anything except for our own services, obviously. But most of the app is not advertising, it's really just educational. And what I mean by that is you can go on the app and you can watch surgeries, you can see patients who have had back or neck problems and see how they've done with treatments. You can learn about different spinal conditions, herniated disc, stenosis, etc. Most conditions that are degenerative we have. There's a big piece of herniation right there. I'm going to get that out. And you can also connect with us. Free consultation, standby, teleconference, MRI submissions, and we're going to keep expanding the app and doing other stuff. So if you have any suggestions to make it better, we're always open to suggestions. The app was developed in-house at Duke Spine Institute by our own app developer, Zach. Of course, Zach has now left and he's in Utah. But I know that working here at Duke Spine is always on his mind. Zach, by the way, if you're listening out there, I'm going to be in Utah this year racing with Arias. We're going to be there in, I think, June. Either May or June, I don't know. I'll let you know, though. If you want to come out and watch Arias race, he'll be competing for a national championship again. For those of you who like following Duke Spine Racing and the career of Arias Duke-Majan, my son, Arias just raced, not this last weekend, but the weekend before in Miami in a very large international race, and he won on Sunday, and he took second place on Saturday. He would have won Saturday as well had he not had a problem with the fuel line being squashed by his seat. The fuel line was placed inadvertently between the gas tank and the seat, and unfortunately every time he went around the double apex he lost power, but he was in the lead of the race, and losing power caused him to fall back to third, and then he outmaneuvered the national champion, the current national champion, Ryan Norberg, for a win to second place, not first. Anyway, great racing down in Miami, and our next race is going to probably be in New Orleans, which will be in March. New Orleans in March. So if you're in the New Orleans area and you want to come out and watch Arius race, you're welcome. Just let me know. Arius races for Kart Sport USA, which is a division of Kart Republic currently. He's a fully sponsored driver, one of, I think, 2 in the United States. And for those of you wanting an update on his career, we're still waiting. We're in the final stages. I think it's going to happen within the next month, that his program for the summer is going to be fully developed, and I can share more information with you. But right now I'm under a non-disclosure, and I can't really share much information at all. But once they give me the thumbs up, and they're probably going to want to announce it themselves, then we can talk more about it. It's pretty exciting stuff, though, if you like racing automobiles. All right, I've got about 5 minutes left. I'm just zapping away here at the herniation. Substantial. I knew it was going to be a big one. We knew that ahead of time. You can actually see the herniation has migrated up right here behind the vertebral body of L4 right there. And I'm chasing this migrating herniation. I'm trying to get as much of it out as I can. I told the patient ahead of time, look, you've got some issues here that may not be able to get it all out. And you can see how stuck down this fragment is right here. It's just scarred to the posterior ligament. Those are fibers of the posterior ligament up there at 12 o'clock. And you can see the fragment has gone behind the vertebral body there, folks. It's pretty interesting stuff. So I may actually need like 10 minutes, okay? Because of this migrated fragment is going to take more time. Good news is most of the fragment is soft, meaning it's easier to get out. And honestly, the easy part isn't for me. Yes, it is easier for the surgeon, but I can stick here all day going at this. I enjoy just digging in and working on things like this. But the easy part really is for the patient. When I say it's easier, I mean for the patient. Because, if I'm here all day working, that's fine. I don't mind it. I enjoy what I do, but the patient has to be under anesthesia all day, and that's not good for the patient. Physiologically, it's not good for the patient. You understand? It's not good to be laying on your belly all day. You start getting swelling and edema and all kinds of physiological problems from laying there and being under anesthesia all day. So we don't want our patient to have issues as a result of that. So the sooner the surgery is over, the better for the patient, and that's pretty much universally true whatever surgery you're having. Anesthesia, as nice as it is not healthy for you to have. Okay, it's just not healthy. It's not natural, it's not healthy, it's not safe. And every minute you're under anesthesia is another minute that you're at risk for having a complication. Make sense? All right.
We have another question.
Sure.
One of our viewers says, I have 2 vertebral
by.
fractures and my pain is horrible. How do you treat that?
Yeah, great question. We have a patient who says, I have 2 vertebral fractures and my pain is horrible. How do you treat it? First of all, I'm sorry you're suffering. I really am. And but the good news is that vertebral fractures can be treated and fixed. So honestly, it depends on the kind of fracture you have. So if you have a vertebral body fracture, which is probably the most common, that usually comes from what's called insufficiency of the bone, where your bone isn't strong enough and your spine just fractures on its own. If that's the kind of fracture you have, oh, a big chunk right there. If that's the kind of fracture you have, well then most likely you need something called a kyphoplasty. Very simple, very easy to do, very safe. So kyphoplasty. That's where we go in and inject some cement, which is really super glue. We inject that cement into your vertebral body. And it just requires a needle procedure to do it, you know? So there's no major surgery done. In the old days when I was training in the beginning, we used to have to do major surgery to fix those fractures. We would take the patient to the operating room for hours and hours, and we would have to operate for hours. And we would have to open their side up and take a rib out and reconstruct the anterior column, do a corpectomy, drill away that whole fractured bone fragment, you know, the whole vertebral body. We'd have to reconstruct the spine. We'd have to put the patient on a special table that could open up and allow us to, you know, put in some big pieces of metal, plastic, in the front of the spine. Then we use a metal plate and screws, and then we flip them over and we put more screws in the back. So it was really quite major surgery dealing with a vertebral body fracture in the old days. Now we just poke a hole with a needle, go into the bone, and fill it with cement. My God, life-saving, amazing procedure. I didn't develop it. Somebody did. This is a bone spur I'm working on. You have anything else I can use to get up in there? I'm just working on this piece that's migrated behind the vertebral body right there.
We have another question.
Sure.
One of our viewers is wondering, can my doctor deny to give me my medical records if I tell them that I'm seeking a second opinion?
Can your doctor deny to give you your medical records? The answer is no. By law, doctors must give their patients their medical records. By law. Your doctor cannot deny you. If you have problems, call us. We'll put you in touch with a lawyer, and they'll write a nasty letter. But the only thing the doctors can do is they can charge you money for your medical records. All right? And that's by law. They're allowed to do that. We do the same thing. You know, it costs us money to print them. It costs us money and time to hire somebody to go find your record and print it out. So they're allowed by law to charge you per page. I don't know the exact amount. I think it varies state by state. In the state of Florida, they have very specific amounts that doctors are allowed to charge patients, and the doctor's office has to follow those. Okay? If they don't, you could also write a letter to the Board of Medicine in your state, Board of Medicine, and just say this doctor is refusing to give my medical records to me, and I'm willing to pay for them, but they just refuse. So by law, you are entitled to your medical records in the United States of America, and by God, you should be able to get them. Nobody should deny you your medical record. Okay? And honestly, I personally can't stand doctors that are afraid of their patients going somewhere else. My patients, if they want to go somewhere else, by all means go. You know, I'll help you. I'll do the referral for you. I'll give you whatever you need. I don't feel doctors should force patients to treat with them. The doctor's job is to make the right diagnosis, educate their patient on the problem. Like, what, this is the problem, this is why you have to be worried about it or not worried about it. And then the doctor should provide treatment if the patient wants that treatment from that doctor. But really the control of healthcare, of a patient's healthcare, should be in the hands of the patient, not the doctor. Not the doctor. At least not in my opinion. Patients should be able to choose who they think is best for themselves. Now in work comp, right? In work comp, even the work comp patients have a choice. They even have a choice. So they get to change their doctor once in the state of Florida. They can switch doctors once. But once you switch, you're stuck with that doctor. So if you switch, you better switch carefully. Yeah, we are in the more painful part of the herniation. This is the back of the herniation. It doesn't surprise me that he's uncomfortable. I probably got 5 more minutes. I would just kind of give him some more. I thought I'd be done by now, but this is a lot worse than I originally thought it was going to be. Like, it's just taking me longer. So yeah, you should be able to get your medical records, no problem. Just so you know, up at 12 o'clock, those are veins up there, and there's some fat up there, and this is just a wad of herniation, just a huge scarred up wad. And I'm just working on it. The more I get out, the higher the chance of success. So it is just taking forever to do, but that's okay. So as a good surgeon, you have to balance the risk with the reward, right? So the reward here is, okay, the more disc herniation I get out, the better this patient's going to do. The more annular debridement I do, the better the patient's going to do. But the risk is, the longer it takes me to do it, the longer the patient's under anesthesia, the more I'm mucking around in there with my tools, the more chance I can cause a complication. So the doctor has to weigh the risks of what they're doing themselves and what the anesthesiologist and the patients are doing during the surgery with the reward. How much better can I make this patient with just a little bit more herniation coming out, Am I really doing anything here that's going to benefit them? Stand by. That's what you got to ask yourself, right? So you want to stop before you cause problems to the patient. Like, right now our patient's very stable, doing good, so I'm not terribly worried. If the anesthesiologist was telling me, we got a problem, patient's struggling to breathe, or I'm going to have to flip him over, or I lost the IV, those are things that would worry me, and I would have to wrap up the surgery quickly. And that can happen in anesthesia. We get all kinds of people who want anesthesia for their shots. And it's like, do you even understand how risky anesthesia can be? They don't know that. Nobody tells them. They need to be told. I believe in informed consent. People need to be aware of what the risks are, right? Because God forbid you have a problem. It's the patient's right to know that ahead of time. They need to know that ahead of time. If you're a singer and you're having a cervical fusion, an ACDF, you're going to want to know ahead of time that you could lose your voice. That's important. It's important to know. Okay, we're still going here. There's still a lot of this, and most of this is within just inside the disc. But it's just ugly looking to me, and I'm worried it's going to push out another piece. So I've got to make sure there's no loose fragments sitting around here that can just pop out. And I can tell you this is really scarred in. This is all abnormal stuff, just scar tissue. Layers upon layers. This is bad stuff. Now it's not doing anything bad where it is. But God forbid it pops out a piece. This patient's going to be back again with more leg problems or back problems. So I got to make sure I get enough of this so that we don't get a free fragment popping out right after surgery. that can happen. And it has happened to me in the past. It's happened to me. So I like to be very thorough, but not push it. We're just about done. I just want to finish getting this stuff out. Stand by. All right. It's looking good. I'm looking all over the place here. Our patient is visiting us from Canada. Again, we love Canadians. We love everybody from around the world. Anybody that wants to come. We don't discriminate. Everyone deserves a chance to come and get a pain-free life. So, Duke Spine is open to helping anyone. Anyone out there? Friend or foe, huh? That has a problem that we can fix.
Man, 4x4.
Oh. This is just more lateral in the disc right here. That's all. We did all the medial stuff closer to the nerve root. This is more lateral. And again, there's just chunks of old herniation here that you can't ever predict what you're going to see when you get in here. But this is just the tear extending more laterally, right? And that's about it right there. I'm going to go back medial, and I'm going to inspect over here. And I've done just about everything I can do for this herniation. And I'll see if we can take a look and see the nerve root. But there's just a little bit more here I want to work on. And the reason this is just the worst level, in my opinion, from a standpoint of pushing on the nerve and narrowing. So this is a lot of arthritis here. I talked to my patient about it ahead of time. I let him know, listen, there's a chance I can't get it all. You're going to have potentially an open surgery. I'm hoping that's not the case, but you don't know until after the surgery is over. So that's why I want to do my very best to avoid having to put this patient through an open surgery. But there's always a possibility I won't be able to do what I need to do, okay, with endoscopic surgery. And fact of the matter is, in most of my patients, about 95% of them, I can get the job done, usually no problem. But in about 5% of them, for example, in this patient, there is a higher chance that I won't be able to get everything out that needs to come out, just because of the angles. Okay, the angles. Remember, I'm coming through the neuroforamen. This is where the nerve is, okay? And I'm having to move around a lot just to get his herniation out. And you can see this laser is struggling to get all this scar tissue out. And it's not the laser. The laser is a brand new laser. It's beautiful, perfect, brand new laser. The problem is not the laser. The problem is the angles and the amount of scarred up herniation there is in here. That's the problem. So you're limited in your view. We're limited. I mean, obviously we're inside the disc, but we're kind of limited nonetheless in like the angle we can attack the herniation with. But I'm feeling pretty good about what we've done. And we're in the lateral recess now. And good news is our next patient we can't do anyway until probably around 12 noon. So this actually works out better for everybody, in that our next patient is going to be delayed because they drank water. But that gives me more time to have some fun here and try to do a good job. Stand by. Let's see if I can grab some of that out with a grabber.
He needs RFA. Do you want the RFA first then?
Who needs RFA?
The next patient.
Oh. Yeah.
Yeah, okay.
Yeah. Well, whatever. I mean, they're not going to be able to do the RFA till noon, right? Or does I mean, he needs to be asleep for the RFA?
Not really. Yeah.
Bed. Yeah. Well. That's the nurse in the room. I love it. And when you have a dispute with a nurse, the nurse always wins. Because a good nurses always focus on patient safety, right? And patient comfort. My mom's a nurse. My sister's a nurse. Hey, don't move. We're almost done. You're doing great. Oh, yeah, that's a big piece. Almost done. Just lay still. Everything's going really good. Oh, yeah. Oh, look at that. There's a big piece of herniation right there. Huge. Oh, beautiful. Hey, let's get this on camera.
Eyes on, please.
This is a
Eyes
good
on,
one.
please.
So I fished that out right underneath the nerve root. Can you guys see this?
Yes, we can.
Sean? Here, yeah. See that? That's a big old piece. Can you see it good? Yep. I'm letting it go. We delivered the baby. Let's see if I can get any more.
Yeah, of course.
You want to say that? What, are you going to make a cupcake with it? Of course you're going to send it to pathology. Oh, and there's still another piece there. Beautiful. I'm happy. The more of these fragments I get out, the higher the chance the patient's symptoms go away. You're doing great. We're almost done, I promise. Almost done. This is really where the pituitary comes in handy, is reaching in and fishing out the bigger pieces of herniation. The laser just can't remove the big fragments. The laser can only release them. Oh yeah, we're just getting a lot of this. This is what I was hoping to be able to do, but I didn't expect to be able to do it. Just because this fragment has migrated just so far, backing up, and it's coming out in a lot of pieces, but the most important thing is it's coming out. And I'm going to keep going until I can't get any more. This is just a huge herniation. You can see it on the MRI at L45. All right. Huh? Beautiful. Just about done. How's he doing?
Do they make different size pituitary tumors?
Do they make different size pituitaries? Absolutely. We've got them all. We've got them all. But they don't all fit in here. Right? So it doesn't matter if you have a big one if you can't use it. All right, just about done. Gotten just about every piece I can out of that hole. There it is. Those are the end plates. I feel pretty good about it. Let me see up there. Let me get the laser one more time. Just about done. This is the L45. This is the one where the herniation had migrated. Migrated means it packed up its bags and it started heading up into places it's not really supposed to go. Up behind the vertebral body above. Making my job much harder, but you know what? We do our best every single time for our patients. All right. There it is. Laser off. I think he's going to be happy. I really hope. Hold on. Let me just check here. There may be something else right there. Let me have a grabber. just under the nerve root in the foramen. I don't really feel any mass effect. Yeah, he's not going to be happy about that. I don't feel anything. I think we're good. That's just some. All right, take that. Let's see if we can find our nerve root here. A lot of inflammation. You see all the scar tissue, the yellowish white stuff? And then there's fat right there. Let me see if I can grab anything out there. Remember, this herniation, I've been taking out in pieces, and those pieces are plentiful. There's a lot of them. Everybody thinks herniations come out in one piece. They don't. They come out in many. And there's just nothing else I can get. So I think that's just some residual annular stuff. But I think the pressure on the nerve is gone. And I think this patient's going to be really happy. Done. So time will tell if we got it all and they're happy. And honestly, getting MRIs doesn't help. Really, we're not treating an MRI, we're treating a patient. And so if the patient's happy and their symptoms are gone, then it's a win. You know? All right, let's go ahead and take a look. I'm putting a little bit of pressure. We do this for every single case. I'm putting pressure on the muscles. And the reason for that is we just basically created a tunnel through the muscle. Muscles are very vascular. They have a lot of blood supply. We don't want any bleeding. So by putting some pressure for a few minutes, we can really suppress any venous bleeding, which is 95% of the bleeding that happens is venous bleeding.
No, just airstrips. Yeah.
Yeah, so no rhizotomy here, right?
Not this one. No.
So let me show you the whole surgery was done through a tiny incision. Can you all see this?
Yes, we can.
Right there, 7 millimeters. Nice work, everybody. All right, I'm going to come to the conference room and answer some questions, and then I'm going to go see the next patient. So I'll come to the conference room first. Great job, everyone. So type your questions up, and I'll answer them for you.
All right, everyone. Thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us, ready to answer some questions. Our first question comes from a viewer on Periscope who asks, "How do you diagnose and treat arachnoiditis?"
Okay, first of all, thanks for joining us today, February 18th, 2020. By the way, my birthday was a week ago. And I'm getting older. It's sad. I thought I would live forever, but it doesn't look like that's going to happen. But it's good to be back. Took a week off, and it's good to be back in the saddle, taking care of patients. I love doing what I do. What I mean by that is figuring out what's wrong and fixing it and educating the world about how good spine surgery can be done. Certainly not perfect, obviously. We're human. We all have issues and make mistakes. But thank God, when you get a recipe for success, you follow the recipe, it works about 98, 99% of the time. So the Duke laser disc repair is one of those recipes. It's an incredible surgery, and I've been blessed in my life that I was able to go and train at one of the best neurosurgery training programs in the world in the University of Florida. And I came out of training with really, really good knowledge and experience about how to take good care of patients and have very successful surgical outcomes and non-surgical outcomes. And after my training was over, I learned how to do endoscopic spine surgery because it wasn't taught to me in my training. There was some endoscopic surgery taught in the brain, where we did endoscopic pituitary surgery, endoscopic third ventriculostomy. So using an endoscope, the basics I learned in residency and fellowship at the University of Florida. But the truth is the endoscope is really a tool of other surgeons other than neurosurgeons. It's mostly, in our world, a tool of orthopedic surgeons. And, of course, in the ENT world that does sinus surgery, they use the endoscope, and general surgeons that do gallbladder removals and other types of endoscopic abdominal surgery, they know how to use the endoscopes. But most neurosurgeons don't know how to use an endoscope. And when I say most, I mean 99.9%. There's probably only 50 neurosurgeons in the world that really know how to use an endoscope. But it's rare. And true endoscopic surgery, like the one you just watched, is really rare right now in 2020, and because nobody's trained on how to do it in neurosurgery. So it's a new technique in neurosurgery that probably certainly less than 1% of neurosurgeons know how to do. But the word endoscopic is sexy, and people like to use it for marketing. The word laser is sexy. Robotic surgery is sexy. So we have a lot of sexy terminologies that are being thrown around in 2000 to 2020. Let's just say the last 20 years. But people really don't understand what they mean or what they're supposed to mean. And in the world of neurosurgery and spine surgery, a lot of times surgeons, I think, misrepresent what they say they're going to do for patients. And I can tell you, true endoscopic surgery, like you saw done today for this patient, is only done by probably 5 surgeons in the entire United States of America. And maybe 5 of them are neurosurgeons, half of them are neurosurgeons, and the other half or so are orthopedic surgeons. I know pain management doctors are trying to get into it, but I don't think it's appropriate for pain management doctors unless they have a very specific situation where they have the appropriate partners that can help them manage complications immediately should they arise. And they should not be doing these procedures. These are really surgical procedures, though they are minimally invasive surgical procedures. Just because the incision is small doesn't mean the risk is small. The risk is massive. I mean massive. As a matter of fact, the risk for doing cervical Duke laser disc repair, in my opinion, is equal to the risk of doing an aneurysm surgery on the brain. the biggest risk of aneurysm surgery is rupture, which causes stroke and death. And doing the endoscopic surgeries also have a risk of stroke, because the carotid artery, which feeds the blood supply to 40% or more of the brain, is in the path of the surgery. And it's literally a millimeter away from where our path is. Not even a millimeter, but less than a millimeter. So what I'm getting at is that endoscopic surgery that you watch today should be done by qualified surgeons that are highly trained in their respective fields of neurosurgery or even orthopedic surgery, but I don't believe orthopedics should be doing it, not with their training. Because orthopedic surgeons really don't do much surgery on the neck and during their training, and they don't really do any surgery on the lower back either during their training. For an orthopedic surgeon to do a spine surgery, they have to spend an extra year at the end of their training where they have to go off and do a fellowship in spine surgery for 1 year. So essentially they're getting a 1-year training on doing spine surgery, because the other 5 years of their residency they do knees and hips and shoulder surgery, foot and ankle surgery, etc., large joint, medium size, and small joint surgery, but they don't do spine surgery. Now that may change in the future to where more orthopedic programs do spine surgery, but right now the surgeons that do spine surgery during residency training is neurosurgeons. And we do, for the most part, we do everything. We do the decompression, and we do the stabilization, and we even do reconstruction, which means realignment of the spine. So I would just caution people, when you're considering having spine surgery and being evaluated for spine surgery, my advice is usually go see a good neurosurgeon. Now, it doesn't mean that an orthopedic surgeon can't do good surgery in the spine. Of course they can, but it takes a very special orthopedic surgeon. And I'd say you rarely find that surgeon. I mean, probably like literally in the United States, maybe 10 really good orthopedic spine surgeons that I would trust to do surgery on myself or my patients. The rest of them I wouldn't. Just so you understand the numbers, 10% of orthopedic surgeons end up going into spine. And those 10% that choose spine as a field for practicing, they have to go do a 1-year fellowship. Now think about that. Do you want a surgeon who's done 1 year of training in spine compared to a surgeon who's done 7 years of training in spine? I would choose the 7-year training usually, but it depends on the individual obviously as well. So neurosurgeons are just better trained, in my opinion, for spine surgery because they have 7 times as much training. And it's part of our everyday routine. Anyway, kind of went off there just talking about who should be doing endoscopic surgery on the spine. In my opinion, it could be a very good orthopedic, but it could also be a good neurosurgeon. But it should not be, at this point, a pain management doctor. I wouldn't trust one. They don't have the skill set to manage complications, and complications can happen very easily. You know, for the Duke laser disc repair, I enjoyed about 13 years, no complications. And but they can happen to anybody. And the better trained the surgeon is, the more experienced your surgeon is, the more prepared your surgeon is, the much lower chance that you're going to have a complication. So be very careful what you do and where you go and who you see for your care. It is surgery after all, and it is on your spine. You want it done right. Don't make the mistake of believing that all spine surgeons are equal. They're not even close. I don't think I've ever heard anybody say that, but they're 100% not equal. Okay? So let's get to the answer of the question. Arachnoiditis. What is arachnoiditis? Well, the arachnoid is a tissue membrane that surrounds all the nerves in your lower back that go down into your legs. It also goes around the brain. It goes around the nerves that go into your arms as well. But when people talk about arachnoiditis, it's basically a abnormal condition that affects the arachnoid membrane. The arachnoid membrane is like a little covering around the nerves, as I said. And arachnoiditis is always inflammation. So arachnoiditis is inflammation of the arachnoid membrane. Now the reason it's called arachnoid, if you understand Latin, is arachnid means spider. And the reason it's called the arachnoid membrane is it's a spider-like membrane. And what they're referring to specifically is it's like a web-like membrane. It literally is like a spider's web. It's very tough, and it literally, you could peel it off, and it has strings that are stuck down to the nerves that look like spider's webs. And so the old people that name parts of the body, the old scientists, the Dr. Frankensteins of the world, when they dissected dead people, hopefully they were dead, they noticed that the different tissues had different qualities, right? So the outer membrane is called the dura mater, dura for tough, mater mother, tough mother. So they call the dura membrane, which is white, and we saw it today during the surgery around the nerve root. That white membrane is very thick, very tough. It's contiguous, it's watertight, and it basically protects the nervous system from like an infection that's spreading under the skin. So it has a protective function. So it's like a mother protecting a child. So they call it the dura mater because it's a tough mother. Now just below the dura mater is something you can't see, and we hopefully never see, is the arachnoid. And that's the next layer, and that wraps around the nerve. So arachnoiditis is inflammation of the arachnoid membrane around the nerve roots. And what it does is it causes clumping together of the nerve roots that are normally not clumped together. So they stick together, and that sticking together changes the blood flow through the nerve roots, alters the blood flow, which then causes some areas of ischemia at times, and just that scar tissue from the inflammation of the arachnoid somehow restricts the nerves and causes pain in the legs. So the symptom of arachnoiditis that most patients that are symptomatic with it have is a burning type pain in the legs. It's constant. It never gets better, never gets worse. It literally is 24 hours a day, and it's just burning in the legs and the skin. Skin is very sensitive. So arachnoiditis is not curable per se of going in and operating on it. And the only way to treat it, in my opinion, that was effective is to do something called a spinal cord stimulator. Now, some people like to put pumps in where you can pump in narcotics around the nerve roots, but I think that's a very bad choice. Doesn't mean you can't do that. It just means I would start with a spinal cord stimulator first. I will caution everybody in this discussion. Just because you're diagnosed by your doctor with arachnoiditis doesn't mean you have it. In my experience, 9 out of 10 patients who have been diagnosed with arachnoiditis elsewhere come to Duke Spine Institute, and we find that they don't have arachnoiditis at all. They have a fixable problem, usually a pinched nerve, and that can be fixed with surgery. Very easily, surgery. 1 hour surgery, complete fix, go on with life normally. So be very careful listening to a doctor that diagnoses you with arachnoiditis. To have arachnoiditis, you have to have findings on the MRI showing your nerve roots are severely clumped together. Okay, that's not even ambiguous, it's obvious. And number 2, you have to have literally burning in your legs, and that burning never changes at all. Like, doesn't matter if you move positions, you play soccer, you do yoga, it doesn't matter what you do, it's always the same. So if you have those symptoms with clumping nerve roots on MRI, then you probably do have arachnoiditis, in which case the best treatment right now in the world is a spinal cord stimulator. We do those at Duke Spine Institute. If you don't have burning and you actually have shooting pain that goes down your legs and it changes with position, then you don't have arachnoiditis causing the shooting pain, and you have a fixable problem.
All right. Our next question comes from one of our longtime viewers. From Facebook, she asks, how do you address long-term pain medication usage prior to DLDR? Does it change how you diagnose and treat their pain?
All right, well, great question. I appreciate the question. And the question really, it sounds to me like is being asked is, you got people who have chronic pain, who have a fixable problem with a herniated disc, and their doctors put them on these pain medications, these narcotic pain medications. And what are narcotic pain medications anyway? Narcotic pain medications are a class of pain medication where there's tremendous similarity in the actual drug that's being administered to your body, in that they're all based on derivatives of opioids, aka opium. And opium is a naturally occurring alkaloid compound that's found in plants, specifically the opium poppy, which is farmed heavily in dry, arid places of the earth, like Afghanistan, Iraq, Iran. Anyway, those opium poppies, which are illegal in the United States and most of civilized countries, those opium poppies are harvested. They're not collected, but they're cut, and there's a sap or resin that comes out, and that's collected after it dries up, and I guess it's somehow turned into something you smoke. Anyway, long story short, the biologically active compound within the opium poppy is opium. Basically, it's a type of a narcotic. All right, narcotic, opium, opiates. So opiates are medical drugs that doctors use that are produced by pharmaceutical companies synthetically. They produce them in the lab, and they're very effective at going into the human body, binding to receptors. I'm not going to get into the details of the receptors, but there's different types in different parts of the body. And these receptors for opium, actually, some of them are along the pain transmission pathway. So pain from, say, you stub your toe, that pain travels up nerves to your brain. Well, the opium receptors short circuit that signal transmission, so that you may have stubbed your toe, it may hurt, but your brain never gets the message because it's stopped by binding of narcotic medications to the receptors in your body along the nerves that transmit pain. Okay, so narcotics are a class of drugs used in medicine, and they've been used for a long time, over 100 years probably, definitely over 100 years, morphine. And these things block pain signals, so it helps people with acute pain. The problem is it doesn't really help people with chronic pain, because chronic pain transmits to the brain through different pathways that don't have the same opioid receptors as acute pain pathways. So that's why, in the United States, you're seeing a big push for the appropriate use of narcotics to treat pain, and that pain is acute pain, not chronic pain. Okay? So I do agree that we need to, as a world, cut back on the use of pain meds, and we need to start focusing on fixing people's source of their pain rather than covering it up with drugs. Unfortunately, the pharmaceutical industries have really led the way and have really been in control, for the most part, of managing chronic pain. And of course, they want to sell their drugs and make money, so they have been promoting doctors to use pain pills rather than figuring out what's wrong and fixing it surgically. So I'm a big believer, personally, that we need to use narcotics very sparingly and only in specific cases of, number one, treat bad pain in a patient when they have horrible pain, but treat it only to get them to the solution that's going to work to fix the problem, okay? So get the problem fixed surgically usually is what needs to be done to get rid of pain. Now, there are obviously people who have pain that cannot be fixed surgically, and in those people, you need to look at potentially using medications, combination medications. But I would always recommend anti-inflammatories over narcotics when possible, as long as the patient doesn't have a contraindication to anti-inflammatories such as ulcers in the stomach, kidney, disease, or stroke risk. So, long story short, we need to get people off of their narcotics. How does the Duke laser disc repair work with respect to people who have been on narcotics for a long time? So let's take a situation where a patient has a herniated disc in their back or neck, and they're having chronic neck pain or back pain, and it radiates into the arm or leg, and they have a herniated disc they want fixed. They've been on narcotics for, say, years to treat that pain. Once the Duke laser disc repair is completed, we can cure the source of the pain. Once the source of the pain is gone, the next step is to wean the patient off of their narcotics. Okay? So there's two scenarios here. Scenario number one, the patient is taking their narcotic for the pain from the herniated disc and nothing else. Scenario two, the patients are taking the narcotics for other pain, like hip pain or knee pain, in which case it's going to be much more difficult to get them off the narcotics because they're taking it for a different problem other than what's being fixed with Duke laser disc repair, which is a herniated disc. So let's just, for simplicity, stick with the patients that are taking their narcotics for a long time for pain coming from a disc that's herniated. Once the surgery is completed, the Duke laser disc repair surgery is completed, the patient can get off their narcotic. They can't stop cold turkey. They have to taper off. And tapering is very important. If you don't taper off your narcotics and you've been on them for a long time, you're going to have withdrawals. And withdrawals can be life-threatening because they can cause seizures. Okay? You don't want a withdrawal narcotic seizure because those seizures are really bad and they can kill you. Okay? Very bad. And once you have a seizure, by the way, you can't drive for 6 months, minimum. So your whole life gets thrown out of socket. Basically, if you're doing Duke laser disc repair, you've had your surgery, we want you to taper off your narcotics. And what that means is you cut your dose in half for a week, then you cut it in half again for a week, and then you stop. So you basically do a 2-week taper. I hope that answers the question.
All right, our next question comes from Periscope again. We have another viewer asking, how are you able to remove so much disc material with DLDR without using something to replace it or stabilize the spine?
Oh, very good question. Very, very good question. And again, I haven't heard a single question from our audience that wasn't a great question. So one of our viewers says, Dr. Duke Majan, I'm watching you do this Duke laser disc repair, and you're in there pulling out chunks of disc. I mean, how much of that disc can you take out before you make the spine unstable? After all, isn't the disc important in stabilizing the spine? The answer is yes, the disc is very important in stabilizing the spine. But what most people get confused about, and it's understandable, is that they think I'm removing the normal disc, but I'm not. I'm removing pathological disc material that's already been herniated, so it's really not functioning normally anyway. In other words, the fragments of disc that I'm taking out are bad, damaged fragments of disc. It would be similar to saying I was driving to work in my car and poof, I felt something, I ran over a nail. And I went out and looked and my tire was flat and I had a nail in my tire. Okay, well, I'm the guy removing the nail. I'm not removing the tire. I'm just removing something that shouldn't be there that's causing problems, and I'm repairing it. So I'm actually not taking your normal disc out with the Duke laser disc repair. I'm only taking the part that's already herniated, so it's as good as gone to begin with. But let's get back to the question. How can you take that much disc out and the spine is still stable? Well, the truth is that we're only taking out about 5% of the disc. Yes, it looks like a lot because it's magnified. So the endoscope doesn't just project a 1-to-1 ratio image. It actually magnifies the view and illuminates. So the endoscope provides illumination, which is light basically, because otherwise the disc is dark, right? Can't see anything. So you need light and you need the actual picture, a video. So if you watch my surgeries and you watch, say, 2 weeks ago, I did a case where we did bilateral disc, and while we were inside the disc on the patient's left side, we actually saw the needle tip from the opposite side because I put the needle in on both sides, left and right. And when you look at that needle tip with the endoscope, it was huge. But the needle tip is really only about 1 millimeter wide, but it looks humongous. The reason is the endoscope magnifies the view and image. So what I'm getting at is the amount of disc material that's actually coming out during my surgeries is not that big. It's not as big as you think it would be because the image is magnified. So, long story short, the Duke laser disc repair does not destabilize the spine at all, because we're not taking any of your disc out. We're taking the herniation out, and we're cleaning up the annular tear. I hope that answers the question. That was our last question for the surgery. I appreciate everyone being here, watching, and asking questions. Asking questions is the best way to learn, and it's the best way to teach. We'll be doing another surgery shortly. It's a single disc herniation on the left side at L45, and the patient did drink some water this morning, so we're going to wait a few hours, and we're going to do that surgery around lunchtime, noon. So that would be noon Eastern Standard Time, because Duke Spine Institute is located in Florida and the Space Coast. I hope you all have a wonderful day. If you don't join us later, if you do, great. Bring some questions with you. I'm happy to answer them.